Hello, everyone, and welcome to today's seminar. The title is After a Decade of Conflict, What Next for Syria's Health System? Just want to wish a warm welcome to all the participants, and this is part of a wider series which is looking to the future about rebuilding Syria's fractured health system. I'm the chair this evening. I'm Susan Eldon, and I'm a senior health advisor at the Foreign Commonwealth and Development Office. We were previously known as DFID. I'm based here in the UK, but we have people dialing in from all around the world, and it's a real honor to chair this evening's session. And I especially would like to thank the Syria Public Health Network in conjunction with R4HSSS, R4HC MENA, and the Syria Center for Policy Research. I hope some of you are part of these amazing networks. They've delivered really strong agendas, great thought leadership, and Syrians are really at the forefront of shaping these emerging agendas, and I've had the privilege of being part of that. So just again, to thank everyone for joining this evening. We have people with firsthand experience from the day-to-day operational realities of delivery. We have experts from around the world, and it's a real privilege and honor. So this evening's session, we want to start by just recognizing where we're at here in March. So in March 2021, we've now marked the 10th anniversary in Syria's uprising, which has resulted in a protracted and violent conflict, which has displaced more than half of its population and left more than 13.1 million in need of humanitarian aid. This ongoing conflict has destroyed the health system and forced the exodus of thousands of healthcare workers, leaving more than 50% of facilities non-functioning. And I sort of pause there because I think for many of us, whether we have a career in public health or whatever background we come from, I don't think many of us have encountered anything to this severity and scale and this duration when we think of something that has lasted for 10 years, 13.1 million in need, and 50% of the health system destroyed or non-functional. And that, of course, was before the COVID pandemic. And the COVID-19 pandemic provides an important lens with which to explore these differences in the health systems and the interventions that will support the future health systems going forward. So without any further ado, I want to introduce our speakers for this evening. We have a great cast of speakers. Our first speaker is Hala Mikhalalati. She's a pharmacist and a global public health researcher working at the Syria Research Group at London School of Hygiene and Tropical Medicine. She's going to provide us with an overview and take us through the current fragmented health systems and how they differ across the countries. Next, we have Dr. Abdul Karim Exayez. He's a Syrian doctor and an epidemiologist, and he's a PhD candidate at King's College London. He's working with R4HC and R4HSSS on Syria and the MENA region, and he's going to talk us through the priorities in the early recovery phase of the Syria conflict. Then Neha Shah joins us from, I think, Al-Hasaka, but she's the Northeast Syria Health Coordinator, and she's going to go through the particular challenges of the Northeast Syria and the current challenges of coordinating those systems, spanning borders and boundaries and the immediate needs and the longer term system needs. And then finally, we have Dr. Rabi Nasser. He's a researcher with the Syrian Center for Policy Research, and he's going to talk to us about the important political economy dimensions. We have about an hour in total, so not much time. I would ask that you, after all of the speakers have gone, if you could please put your questions in the chat, and I hope we will have some really good discussions at the end of all four speakers. So without further ado, I'd like to hand over to Hala to provide us with an overview. Thank you.
Sure. Well, thank you for the introduction. I'm really honored to be speaking here today along really exceptional speakers. And I'll just get started. So yeah, can you hear me well? Can you see my screen well? Great. yeah, 10 years now from the Syrian revolution, 10 years almost of ongoing conflict and armed conflict that really affected not only health system, but all aspects of life in Syria. But talking about health system in particular, and starting from pre-conflict health system, while some will consider that it was slightly providing free services, while Syria was really going into epidemiological transition from going from communicable diseases to non-communicable diseases, and other health indicators were getting well, but the pre-health system stressors has been really already there. So poor expenditure on health, which is relatively less than any other country in the area, weak health system governance structure, corruption, and I would say systematically corrupted system, because if you were not corrupted, the system will eject you. Poor accountability, transparency, and community engagement within health system planning, inequalities and disparities, especially between urban and rural areas and remote areas, where disparities in all health services were existed. Also, the health system was heavily medicalized health system, so less and less usage of primary healthcare and triage and other referral systems, and dependency on specialist and secondary and tertiary health services as the first point of access for health services. And of course, talking about health workforce, it was also unequal distribution. So there will be like huge amount of specialists and health workers, nurses, doctors, and other paramedics and allied health workforce in the big cities, but in other places like Ness, which we'll talk about later in more details, was already from the beginning really well under-resourced. So the conflict, as I've mentioned, has affected all the aspects of life, and not only health system, but it has affected all aspects of health system. So when we talk about health system, we talk about the system building blocks, which is the service delivery, health workforce. So there was interruption in training, there was migration of health workforce, health information system, which was hugely unexisted before. So it's hugely weak already, and after the conflict it's not there, we can say. The access to essential medicine has hugely affected financing and leadership of governance, of course, but also it affects patients' engagement in the health system. So access to health services, coverage, quality, and safety for people to access health services was affected. And that's, of course, that will affect the goals of a health system. So if we talk about the improved health of a population, the responsiveness of a health system, how people's needs are met, social financial risk of health included, and improved efficiency of a health system. And also the social determinants of health, so education, financial, and social construction have all affected by a health system. And that results in a really unique health system in the case of Syria, which was fragmented hugely into four kind of sub-national health systems. So we do have the areas under Turkish control, which is in the north of Syria, and mainly in the north of Syria. We have the northwest of Syria, areas under the opposition control. So that's another health system. And we do have the health system, which is under the area, in the areas under government control, and also in the northeast Syria, the de facto autonomous self-administration areas. So each one of these health system has their own leadership, governance, structure, funding streams, strengths and weaknesses, and there is little collaboration between both the four of them, and mainly there is huge under collaboration in regard of data health information collaboration coordination. So what are the key differences in between those subnational health systems? Areas under the government control, so it is hugely centralized. So the Ministry of Health really deal with everything, and everything needs to, like, all decision making and all things needs to be under the provision of the Ministry of Health, and it's increasingly private now. So there is poor investment in the primary healthcare, as we said before, even before the conflict, and now more and more where the government cannot really provide because there is no funding for it. So it's more and more the investment is getting less and less. Heavy reliance on secondary and tertiary health care, inequality driven by lack of accountability and unequal geographical distribution of services, facilities, healthcare workers, and that all was worsened after during the conflict. In the northwest of Syria, so it's hugely fragmented itself. So in northwest Syria, we have a lot of actors that provide health services, and each one comes with different agenda, different kind of priorities, and because there is some sort of poor coordination between of them. Sometimes we end up with overlapping services, and some areas are under served. So poor governance once again, and weak health leadership, heavily reliant on cross-border aid through Bab el-Hawa and other borders between the surrounding countries of Syria, and that is really depends on the political mood. The international political mood, and this is really a weak point that sometimes can put people's health under significant danger. And not to mention the significant destruction of health infrastructure. I mean, we have all listened and heard about how health facilities and healthcare workers were systematically attacked by the actors in the Syrian conflict. Northeast Syria, I won't be talking a lot because I know Niha will dig down really in that, but it's also, once again, it's under-resourced and underdeveloped from the beginning. So services prior to the conflict were at the minimum. The closure of Yarubiya border crossing in January 2020 has adversely affected health, and humanitarian provision, and has a huge implications on people's health and the provision of services. So the Turkish-controlled areas, which is in the north of Syria, follows the Turkish health system model. Not a lot of information we do have about it, so it's not very there is a lot of transparency in talking about what is happening. We don't know a lot. Mainly the health workers are Syrian, but in decision-making positions, they will be Turkish mainly. Also, there is a huge poor coordination problem with this areas and the other, northwest of Syria and northeast of Syria, and you can imagine how that can affect the new pandemic, and how that would affect the people, programs that implemented in order to control the pandemic. So we've talked about the disparities in geographical distribution of health care facilities and health services. So if we talk about only health workers, so we can see that in Damascus we do have more than 40 kind of health staff per 10,000 population, whereas in areas like, sorry, I just can't see, Al-Hasake or Al-Raqqa, we do have less than 4 or 5 health staff for 10,000 population. So huge disparities between people, between different areas in Syria. So what are the key health system challenges in the health governance and leadership, if we talk about it? So huge influence of UN agencies, international NGOs and external donors on health governance. And what happens during a conflict is that because people will just think that it is an emergency and will start providing services that is very emergency in nature. So there will be lack of more strategic, more kind of sustainable developmental nature to it. So it's during the last 10 years, it's all about multi-actors, multi-donors with different agendas, part of coordination, and all are for basic, very responsive responses. So there was no really building to a more sustainable, more owned by the community and led by the community health system. It is fragmented and there is no coordination between the four of them. Disempowerment, so because with all of these actors, of course, there will be less and less power to local authorities and to people to act on it, and poor regulation, which has affected a lot of aspects. For example, medications and psychological medications. There is a huge problem in northwest Syria where those medications are sold really unsupervised and unregulated. Health financing. So corruption has been, as I've said, it's systematic corruption. It's embedded with different aspects of health services delivery. Poverty and unemployment has also affected people's health and people's access to health care. Restricted funding, and sometimes the funders have their own vision on where the money should be put, and no one from the local authorities or the local actors will be able to influence those decisions. The unequitable resource distribution, so humanitarian and financial misappropriation of resources based on ethno and religious lines, and also, once again, local communities, local actors cannot really influence those decisions. Health service delivery, so once again, cross-border, it's really very depending on cross-borders services like medications, training for staff, healthcare workers, equipments and other consumables. So, and it's very depending on the political and international kind of mood. So the Yarubiya example, the Yarubiya border example. With all of this fragmented, really very weakened health system, how it is the picture with the COVID-19. So as of the last report for the WHO, 45,400 almost reported cases in Syria now, COVID-19 cases, 1,761 deaths across the whole of Syria. So, but it is vast underreported. So we know that there is lack of capacities to do reporting. So those numbers are high, much underestimating the real numbers. Inequitable inequitable response, fear of reporting sometimes. It's from people and also from the different kind of health systems. At the beginning, they were just denying that it is there, and also for people and with stigma about it. And so they would not also report the cases. Insufficient resources across the country, not only in the northeast, northwest, but also in the under government controlled area. Healthcare workers inside Syria had the highest level, one of the highest levels of getting the COVID-19. That's because of the lack of PPEs and other equipments, and also because of the pressure, because it's already the health facilities are understaffed. So all of this, and coupled with the economic and financial status inside Syria, with inflation and the difficulties that happens, the current situation is really it's not promising at all. And also, one of the challenges is that because of the lack of testing, so the variants are in Syria now, we don't know about them, so we don't know about, even if the vaccination has reached to Syria, what variations are in there. Is it really compatible or not? It's also a question. Poor coordination, data sharing and information sharing between the four kind of subnational health system is also affecting their response. So, take-home messages. COVID-19 has exacerbated existing challenges within Syria's health system, which has been adversely affected by a decade of conflict. After 10 years of armed conflict in Syria, Syria has left the health system fragmented, politicized, and unable to meet the needs of the people across the four health systems. Each health system has its own governance, leadership, funding, and limitations. The needs to build robust, good quality evidence for strengthening health systems, not only post-conflict, but also during conflict and unrests. We need better communities engagements approaches and better supporting for universal health systems that really make sure that health is provided to all. That's it by me. I hope that I haven't gone loads. So thanks for listening. Just acknowledgement that there is a huge number of Syrian health professionals working on the grounds, has really worked with us, accepted to be interviewed and share their expertise and knowledge. And thanks to my colleagues Saula and Manar. Thank you.
Thank you, Hala. That's a lot of complexity to try to wrap up succinctly, and you've done an excellent job. So thank you so much for that. We're going to turn now to Dr. Karim, again, who's the epidemiologist and Syrian doctor working at King's College London, and he's going to talk us through the early recovery phase for the Syria conflict. So over to you, Karim.
Oh, thank you, Suzanne, and thank you, Hala, for setting the scene. So myself, I was part of the health system before the revolution in Syria started. I was doing my training program in neurosurgery, but then I shifted my focus to public health as a result of the different emerging health threats, starting from the polio outbreak in 2013 and the triple burden of trauma, NCD and CD. So now most of my work is focusing on health system strengthening interventions in conflict and post-conflict. So talking about health systems in conflicts in general, our understanding of health system in complex settings is somehow limited. So most likely our understanding is based on these quite old frameworks of the different control knobs, for example, or the building blocks of WHO. And even the modified version of this WHO framework, which had tried to put patient engagement with it and some other health outcomes into the core of this health system. I think the application of these frameworks in complex settings is very limited. And that's why I think our understanding of health systems in complex settings is poor. And most of the times we talk about health intervention, sporadic and parallel health systems without, one unified or just without strategies for health system strengthening. We proposed recently a new framework for how to understand health system in complex settings. And because, in complex settings, it's very complicated to approach health as one element. So we need first to think about this circles, the dark blue and the light blue ones. So the external environment would have a lot of influence, donors, international organizations, mostly funders, and also the social determinants, social and political and economic determinants of health would be kind of the environment where we need to look at health system in. And then we have two levels, I would say the inputs level and the outcome level. In terms of the inputs within the supplies, the two things that affect supply side, and supply side are mainly the 6 different blocks. But the things that affect the supply side are policies, which are related to political commitment, the different leadership and governance, which is severely affected usually in complex settings, the availability of health workforce and other issues here, and the demand side, which are usually overlooked in complex settings. And then we need to think about the outcomes, because we talk about a very kind of dynamic environment in complex settings, we need to differentiate between the different phases of the conflict. So in pre-conflict and conflict phase, in terms of outcomes, we look at saving lives and access and responsiveness, while the more we go towards early recovery, we need to think about different outcomes. In addition to these ones, we need to think about social and financial protection, safety, equity, and other outcomes. And later in the development phase, we need to think about universal health coverage and quality of care. I think this kind of dynamic approach is missing in complex settings. And in Syria, if we would like to apply this element, we need to understand the new burdens of the health system in Syria. Now the shift between the top morbidities and mortalities in Syria was enormous. So conflict and terror was at the bottom of the list. Now it's number 1, but in the same time we have NCDs and CDs in the same time. So we have triple burden to deal with. And this is represented by the triple burden here before and after conflict. So key priorities when we will think about early recovery phase in Syria. And the outcomes level, we need to start thinking about health equity, social and financial protection. Most of the services in the humanitarian phase were provided free of charge, while now in the early recovery, there might be new schemes for health financing. And we need to think about how we ensure this financial protection. Quality is an important issue. Integration of services. Usually different actors, they provide different set of services with really minimum integration between services and between actors. Now it's the time to think about integration as a priority and the outcome level. Comprehensiveness is another issue, because a lot of health services are not covered at all. Think about some NCDs. Cancer treatment is not available in large areas in Syria. So we need to think now, it's not acceptable for 10 years cancer patients, they need to cross the border with very limited functional referral mechanism between the different neighboring countries. Responsiveness is again another issue, and the COVID-19 pandemic proved that this outcome is important. And to translate these outcomes into practice, I think key areas that we need to think about in terms of interventions are first, sustainable health infrastructure. As most of the infrastructure in Syria has been destroyed. And especially in some areas of the country, more than other areas, where some areas, especially Northwest, where it's witnessed the brunt of atrocities in terms of attacks on healthcare. So we need to think about sustainable health infrastructure rather than supporting, for example, a school to be a health facility. Now we need to think about sustainability. The human resources, mainly protection, because still protection is a major issue, even if it's an early recovery phase. But issues of arbitrary detention, we've seen this in the areas that were taken over by the Syrian regime in the recent few years. Arbitrary detention, torture, and other issues related to protection of health workers. Health education now should be a priority. For 10 years, in some areas of in Syria, the health education was interrupted. There have been some initiatives, and these initiatives needs to be structured and supported. And then supply chain. as we know, the supply chain was interrupted. Again, for example, in northeast of Syria, and maybe Neha will talk more about this, especially after the closure of the cross-border between Al-Yarubiyya point from Erbil to northeast, there has been a lot of shortages in terms of supply chain, and this affected the COVID-19 response. Health information, we need to think differently about health information. Most health actors in the humanitarian phase, they think about health information as, you know, a donor compliance and reporting, while now there should be more systematic approach. Think about maybe HIS2 or even electronic medical records. And we're talking about good examples here. Referral mechanism. If we think about integration, referral is important. Now, you know, even before the conflict, Syria had very weak referral mechanism because the different levels of healthcare were really hardly established in terms of primary healthcare, for example. And we talked about health financing. We need to think about, this dependency of health system on humanitarian funding need to be looked at differently. So there should be new schemes, new models for health financing on how to think about projects that generate fund for health system. Think about different insurance schemes, for example, and social insurance schemes. Some good practices. In order to understand maybe these interventions, I will reflect on some good practices that have been happening in the last few years in Syria and how it's important to build on these good practices. Please let me know, Susan, if I'm out of time. I will give quick examples of polio response between 2014 and 2016. The idea was that if we're going to vaccinate each single child and we need to go door to door, then there is an opportunity to build a functioning health system rather than, you know, supporting sporadic vaccination campaign here and there. As a result of almost 6 vaccination rounds between 2014 and 2016, we were able to establish and strengthen a technical health body represented by the Syrian Health Directorate, which are basically technical bodies not affiliated with neither of the governments, but focusing on establishing these local coordination mechanisms. Other examples, you know, based on these vaccination campaigns, the Syria Immunization Group was established, and until this point, the Syria Immunization Group is the main actor in northwest of Syria in terms of vaccination, and they were able to re-establish the EPI system, the expanded program for immunization. In terms of other services, for example, health information, PHT, infection protection and control, the referral mechanism, there has been in the last 2 years in northwest of Syria a new approach represented by what is called central projects. So rather than focusing on one specific health facility, on one specific project, some actually they started to think about thematic areas that they established central projects for, and they support a central team to think about to oversee the process. For example, for DHIS2, now there is a functioning project team called DHIS, not really affiliated with Ministry of Health, because there is no Ministry of Health, functioning Ministry of Health in northwest of Syria, but they act more or less independently to coordinate between the different actors in terms of health information. Similarly, there have been some projects for PHC, referral, and IBC. Protection of health workers, in terms of documentation, some protection mechanisms, I think these initiatives need to be studied and looked at. For example, the early warning system, the HALA system, this has been a new innovative approach on how to predict risk and mitigate risk. Other health education, there have been some initiatives, as I mentioned. For example, in northwest Syria, after the collapse of the health education there, some actors, they established the Syrian Board for medical specialties, and until this moment, this board acts as a medical specialty board to coordinate not only the clinical training programs, but also other aspects related to nursing schools and some other also supporting health education initiatives. Community engagement is an important theme. This was represented by a recent example was the COVID-19 response, where a new governance system was established by Idlib Directorate and the White Helmets, and they established the Volunteers Against Corona, and the early prediction of risks represented by the early warning and response network. They predicted the risk of flu-like illnesses a year before the COVID response. Partnership between multidisciplinary equal partnerships is a very important theme. And they, maybe I don't have much time, but I will give two examples. The project that I'm part of, which is Research for Health System Strengthening in Northern Syria, this is funded by 4 years project funded by the National Institute for Health Research in the UK. And we established a new network or partnerships between us as a King's College, as an academic institution, with an NGO, a Syrian NGO, the USAN, the Union for Medical and Relief Organizations, plus involvement from the Syrian Public Health Network, David Knott Foundation, and other actors. And the aim is to establish working groups for each thematic area related to health system strengthening. The last point, because I know that I run out of time, we need to, can we do these interventions in the same way in the different areas of Syria? The answer is no, because we have different health systems. We have the Ministry of Health in Damascus, the Syrian Health Directorate in the northwest of Syria, the Turkish Ministry of Health here, and also the self-administration in northeast Syria. The issue is that the challenges and the opportunities in each one of these areas are different. That's why we cannot, approach health system strengthening in these areas in the same direction, in the same approach. And one very important point I would like to mention here, the conflict is not over. And even in the early recovery phase, there will be issues related to human rights violations. And we need to ensure that the health is not used as a weapon of war. Some parties to the conflict might use the health as the health system to either deprive population from health access or to reward population, and this should not be allowed. That's why I think a solution that I propose is to make this health system strengthening conditional to human rights. We know that humanitarian principles were kind of the guiding principles in the humanitarian phase, while now we have early recovery and development. So we need to be conditional to human rights. And another solution is go local and go small. Do not think maybe about supporting the whole health system relying on the Ministry of Health in Damascus. This is not a good idea. Think about one maybe thematic area, and I'm sorry for the background noise of my daughter. Think about one specific area, for example, IBC, and implement a project here, and maybe go locally, engage with local actors. And this is for donors. And maybe, yeah, that's enough for now. And maybe in the question and answers, I'm happy to take questions if needed. Thank you.
Karim, thank you. That was so rich and so important. And I just have to say your examples of this SIG, eWarn, SPOMS really spoke to my heart to see those live examples being used and really bringing that to reality. Also really appreciated your daughter's echoing the conditional on human rights, which I think we all agree on. So thank you for that part. Next, I'll hand over to Neha, who I think is going to take us through the Northeast Syria response. So thank you very much. Over to you, Neha.
Hi, everybody. I have been traveling all day, so my PPT is half ready, but I will share it. Should I share my screen, Susan?
Yes, please.
Okay. Is it available now? Can you see it?
Yep, we're good to go.
Brilliant. So, thank you for giving me this opportunity, first of all. I think I am representing an often forgotten side of Syria that sometimes is very less talked about. I will not take too much of a time in terms of my presentation. I represent the NES Forum and the Health Working Group of NES, and I've been here for almost 3 years, so I'm partly Arabic, partly Kurdish, and partly Indian. And that is how Northeast Syria is, if you would ask me. It is partly Arabic, partly Kurdish, and they're all Indians at heart because they love all the Indian movies. So moving forward, I think a lot of speakers have already covered the 10 years of conflict, so I would miss that section. And we all know that the burden on Syria is specifically very high. I would just want to highlight that there are 12.4 million people in need. And the COVID-19 pandemic has changed the demographics of this region much beyond. It has caused a lot of economic constraints. It has changed the entire economy. The cost of a food basket has gone 230% in the last 6 months. So the first time 3 years ago when I arrived, the Syrian pound was 470, and right now it is 4,007. So that's the kind of change that has happened in this country's economy. And we need to understand that we cannot just watch it happen. And we really need to act now. And we really need to understand that the conflict is not going to solve on its own. There are going to be drivers and forces that are going to be engaged in this. This is people in need by demographics, by age group, by disability, and by sex and by population. I would go straight away to NES. According to OCHA figures, there are 2.6 million people as the estimated population. There has been a lot of debate given the context in NES is quite sensitive on the total number of population of NES. And I would just give an example. For example, the population of Aleppo is in the OCHA figures as 4.78 million population. And the whole of Aleppo is covered under the government of Syria figures through OCHA. However, Manbij and Enel Arab districts are actually in northeast Syria. And if we just put like 20% of that, then the entire population goes approximately above a million. So it becomes 3.6 million instead of 2.6 million.
Neha, can I interrupt you just a second and ask you to go to slideshow? I'm having a little trouble seeing some of the slides on the details. Sorry to interrupt. I just wondered if you could make those slides a touch bigger on slideshow. Thank you.
Okay. Are we better now? And I go to slideshow. Is this better?
That's much better. Thank you.
Brilliant. Okay, so this is an example that I was trying to give, that if you look at the population estimates and the areas of coverage, there are definitely, no clear boundaries, and different population estimates give out different figures. However, for the purpose of our interventions, we consider anywhere between 2.4 to 4.6. And that's a huge gap of 2 million people who are counted on either side or sometimes discounted on either side. In terms of our overall response in Northeast Syria, we have 42 partners and we have 919 communities reached in 2020. If we look at Hasakeh, Raqqa, Deir ez-Zor, and Aleppo, if you look at the response overall, as you can see here from the map, you can look at the areas that were carved out at the time in 2019 when we had the conflict between Turkey and the Northeast Syrian regime. And so the response kind of diverted towards that. So you see a U, which is actually a diversion that has created, and the straight line has been bifurcated. So we have a big response right now in Raqqa. We have a big response in Hasakeh, and we have a big response in Manbij. However, this is an overall response, not just health actor response. And I would go to priorities and health actor response in a bit. But I wish to highlight that there are needs and gaps that are there in different regions. There are people who are able to reach those regions. However, as my previous speaker highlighted, there is no comprehensivity in the response. You are not reaching them in a way that the aid is sustainable, that the response is sustainable, and that it is kind of, leading to outcomes that should come out with the amount of investments that's going in. So this was something that we did, an exercise that we undertook for the IDPs and the returnees. And if you see that health is a priority need, 37% reporting it in the top 3 priorities. So as it was highlighted, health, education, livelihoods, and food. I think these 4 sectors together with WASH are the major priorities that are there in each group that we come across. Now moving on to the health infrastructure. We have, I wanted to show, Susan, is it allowed? Can I show a dashboard if you would not mind?
Yes, but quickly, we're running low on time. Thanks, Neha.
Fine. So let's not go to the dashboard. I would just highlight that there are 85 facilities supported by health partners. And then there are 10 facilities that are supported by local health authorities and health partners. So across NES, 95 facilities are being supported by health partners, and 45 facilities are supported by the local health authorities. And these local health authorities actually are the same people who were probably at some given point of time working with the Ministry of Health and now are, a de facto administration as the self-administration of NES. Now, if you look at the total number of partners in camps, it is extremely crucial that I am able to highlight when you look at the health figures that the camps of Abu Khashab, the camps of Membich, new and old both, the camp of Surekaniye, the camp of Talsemen, the camp of Twahina, and also to include Roj, are the camps which are informal camps. When I say they are informal camps, that means that they are not recognized by the UN as a formal camp. So Al-Hol, Arisha, Mahmoodli, Neuroz, and Rosh, the top 5 are formal camps, and the bottom 6 that you see are informal camps. And then beyond these 6, we also have camps that are called as informal settlements, which are not listed in this figure. Now, overall response is very weak, and I would basically talk about the gaps in the health response in this slide. So primarily what we have identified is that as both my speakers highlighted the supply chain gaps, and supply chain gaps are not just for NES, to be honest, but they are more pronounced in NES because of the fact that Yarubia closures happened and then COVID-19 immediately struck, and then the GOT offensive. So in the last 1.5, 2 years time, we have had 3 big events happening. First, Yarubia was closed, then there was a GOT offensive, and then COVID-19 pandemic hit Northeast Syria. So the entire supply chain has become ruptured, especially for NCD medications, pediatric medications, cancer medications, as was already highlighted, special medications. I mean, right now, if there is a snake bite that happens in Membich or Raqqa in the Euphrates region, which is a very common thing that happens in summer in Northeast Syria, if there is a rabies bite that happens, they are out of those medications at the level of hospitals. And which is why I say that rebuilding the health system is the top priority, because even at the level of hospitals, Syria was a hospital-based, glorious hospital-based infrastructure rather. And when I go to Membij and I see the ruins of Raqqa Hospital and I see the ruins of Tabqa Hospital, it breaks my heart open, because this system was it trained some of the best people. Some of the best medical institutions were in Aleppo, and some of the best doctors from Aleppo are working in Membij, and they talk about these rebuilding their infrastructure, supplying them medications. There are regions in Membij and Kobane, and I was there last week, that have not received vaccinations since 2018 September, because there is no access, and because the vaccinations are only provided by the WHO and the UN chain, and the cross-border actors are not engaged in vaccination. So the only actor that can bring in some amount of vaccination in a very ruptured EPI chain exists in one facility in Membij Hospital and one facility in Kobane, which is also on the eastern peripheral region. So it is not really something that is accessible. Moving on, I have already highlighted the gaps in the camps. I would just want to also highlight that there is a lot of challenge that happens in terms of emergency case management, because most of the services in Northeast Syria are ending at 3 p.m. So after 3 p.m. till the next day in 8 p.m., you do not have any services. I do not have any ways of reaching to a population as big as 2.6 million, and they do not have any way to actually seek access into these hospital networks, which are fragmented, and the night facilities and the emergency facilities being that discouraged. And a very close example of that was the Al-Hol tragedy that happened with burn cases. And there were second-degree, third-degree burn cases that could not be managed at the level of a hospital. And that is when, these gaps are, they're put on your faces, and you can see those gaps pasted on your faces, and you can't do anything. I was in Hasake National Hospital at that given point of time, and there was nothing that we could do. We had no pediatric IV kits. We had no plastic surgeon that could have repaired any kind of, normal saline or any kind of line into those patients. So I think it is very important that we understand that this health building is not just a governance level building. It has to be a building that is built upon the blocks of hospital-based infrastructures, the CPHCs doing the work that the CPHCs are required to do, and the actually ensuring that there are services available in night, because all the emergency deliveries are happening in night, and women are delivering in their tents. So everything that I've said is kind of summarized in here in terms of what we are trying to now achieve, and the minimum commitment that we are trying to achieve. For example, formal versus informal camps, and a multi-year resiliency-oriented funding from donors, because it's extremely crucial that we don't give 6 months fundings anymore. Because if we continue to give 6 months grants, there are 2 months of gaps. And in those 2 months, whatever you build in the last 6 months falls flat. And those people do not have those kind of services. So I think it's extremely crucial that we are able to achieve a sustainable funding cycle and a sustainable response, which caters to especially emergency needs of this population 24/7 and not till 3 p.m. That's all from my side. Thank you. I had something on COVID-19, but I think we have run out of time.
Yeah, thank you so much for that. We appreciate your passionate advocacy and also your experience on the ground. And you really spoke to the issues, particularly around short-term funding and access, and how those are such critical challenges to even making this work. So thank you. Rabi, I'm afraid it's over to you to wrap us all up, and we don't have a lot of time left, but I think you're going to talk us through the political economy side of things. And I just wanted to point out to folks, we might run a little bit over time here, but there's questions and answers in the chat bar, and we'll probably use that for using that on the chat function. But Rabi, over to you.
Thank you very much. And yeah, it's my pleasure to be with you today. And I will try to do something in 7 minutes, which is very, very challenging, but at least I want to highlight the key points and messages that we can build on it later on. This work is based on the team of Syrian Center for Policy Research, which is working on different topics regarding Syria since 10 years. And a lot of fellows and other partners and institutions. So it's not an effort of recent or one person or so. What I want to start with is the idea that Karim mentioned, that let's have a local intervention. And I just want to argue that we are doing that since 10 years. Let's have some solutions. Let's have some urgent solutions. Let's do our best in one specific area. And I'm afraid this is not working because of the political economy of it. We are in the middle of the war. It's intractable conflict. The fourth regions without a military battles. So in the last few months is not an indication that we are over the military battles. And I think we are building all the foundation to continue this battle. The key actors are happy to continue with the same strategies. At least this is what they announced. So we can't expect that this will be solved or overcome during the current situation. I will give a letter of hope at the end, but I think the rest will be it's a devastating situation. So I just want to use the political economy framework to understand this as much as we can. I just want to remind you that we are in the region of conflicts. In the last 100 years, we have different type of external, internal, hybrid conflicts, and Syria is at the heart of this. I don't want to go through any details, but we have to understand that this conflict's dynamics associated with the domination of authoritarian regime, with the military/security services controlling the political power, and this affects the whole governance of the whole state, and including the health system. So in understanding this is very important context, and this is the idea of political economy, is to see the different factors that determine the health outcome at the end. We are talking about a lack of transparency, accountability, participation, which reflected in low equilibrium of development, plus huge inequalities. We have a region with huge natural resources, which affect the political structure of the region and affect all the conflicts in the region, including the Syrian conflict. And this is very important to say that we shifted from the welfare state, quote unquote, in terms of the public services, toward a new liberal structure. The new liberal structure fits the authoritarian regime. So we have authoritarian regime in the region, plus a new liberal policies, market-oriented policies, which is reflecting how this inequalities increased without any kind of channel to reduce or mitigate the bad impact. And finally, the identity politics and all of those factors reflected inside Syria and affected the health system. The identity politics using all kinds of identities to flaming the conflict and expand the differences and encourage the people to kill each other. Unfortunately, our chance to have the Arab Spring as a reflection and transformation of the socioeconomic and political situation failed to do so, at least in the last decade. And this is the introduction to go through how to understand this impact on the health inside Syria. In the center, we used like the assessment for the 700 regions. So we divide the country into 700 regions, and we try to assess the situation in terms of the health outcome, the health system, and the determinants. And through that, we try to see what is the impact of the conflict and how the dynamic make the conflict and the health actors part of the conflict economy, part of the authoritarian groups and armed groups, and how they build this kind of complicated relations which affect badly the institutions. So we have conflict-centered institutions, even when we not intending to do so, like a civil society that want to help and do a humanitarian work, but because of the structure of power, they build some relations with the authoritarian or armed groups, which make the governance affecting negatively the population. What I want to say before going through the determinants that we can go in details for that is the dangers of the breakdown threshold. That what there is like the people exposed to 10 years of poverty, 10 years of lack of education, 10 years of lack of participation, displacement, and we can count this. The resistant to this kind of pressure and risk factors can be collapsed and in a dramatic way. Now we can see in the last 2 years that after the reduction of military operations, there is a huge drop and deterioration in the socioeconomic situation. And this is not just because of COVID, this is because of lack of hope, because the people depleted all their resources, social and tangible and intangible resources during the 10 years. So the continuation will not be linear anymore and could lead to a huge collapse in the near future due to what we know and what we don't know. Like in the burden, we don't know about the disability, about the traumatic diseases. Most of the chronic diseases, we don't have a clear assessment to the huge burden that we have now. I just have 3 classifications of the policies that have been used to continue to flame the conflict by the subjugating actors. What I use subjugating actors for the armed groups or political powers across Syria. So we have, like, the first thing is the normalization of killing. So we have the collective punishment in different situations. We can go through this, but this is something that collapsing and violating the right to life and all the other human rights by eliminating the people. So I'm talking here about how the key actors using the health policies or conflict-centered health policies to destroy the health of population directly through the injuries and killing, through torturing, kidnapping, and sexual abusing, human trafficking, and of course the siege and for the people, preventing them from access to the basic food and health services, and in terms of displacement. The intermediate policies, which is the policies that distorted the health system, and in this regard, we have a huge substantial transformation from resources from the health for public to the health of military competence or the military system. So this is a huge reallocation of resources. The second way of reallocation is from health and education and other public services to the military and conflict investment and expenditure. And more than that, it's increasing the discrimination within the health system against groups or people based on the loyal or not loyal. In general, the public sphere disappeared or shrank a lot in terms of the public services, and the key actors left this for the civil society, private sector, and to the international community. And in this regard, we can talk a lot about the dangers of this kind of filling the gap as like to have more social support with their loyal bases, and to punish the others in terms of using the civil society, private sector, and international community to close this gap. There is the direct targeting for the infrastructure. So the readiness, we have a lot of indicators about how the readiness, effectiveness, and the fairness destroyed in the health system. But this is an intention policy. This is not a random, and we can go through this in detail. Now, the most important thing is the long-term policies, which is destroying the determinants of health. So we're shifting from authoritarian political regime to different regimes. I mean, labeled by the tyranny, labeled by lack of good governance, lack of democracy, etc. And this is, according to our causality analysis, this is the most important factor that determines the efficiency of health system and the effectiveness on the outcome. The other important issue, which I think is under-researched as well, is the social capital. So we have a collapse of social capital, which was very important part of holding the community in Syria after all of these 10 years of conflict. And unfortunately, this degradation of social norms and lack of shared values make the ability of community to have better health lower and lower. And we have what we call the negative social capital, when we have this fanaticism and the people try to kill the others, prevent the others because of this kind of fanatic identities or fanatic use of the different identities. Of course, we have a huge generation inside and outside Syria, who is the children and the families who are displaced or deprived from decent work, deprived from education, and we will see the impact on health, not just now, in the future. And that's why I think we have to predict that there is a huge collapse will come in the future, because this 10 years destroyed this foundation, which is very important to the outcome of health and for the future generation. The food insecurity, as I mentioned, it is not like the food insecurity, like we have the estimation of poverty like 96% in 2020, and with a huge poverty gap. But this is not the story. The story that we have this for 9 years from 2012 until 2020. So this kind of a huge, deep deprivation, huge injustice will be the engine of the continuation of deterioration. And that's why humanitarian intervention will not play a role of this. We have the conflict economy. So unfortunately, for example, we don't have assessment for at least public assessment for the role of UN agencies, INGOs, civil society in the conflict economy. So how they involved in this conflict economy and how they reproduced foundation of war, although they want to reduce the burden on the people, but they are now part of a bigger machine that destroy the health outcome. And I can't go through all of these details, but I want just to share with you that we look for these determinants, and many of those determinants are very important, like what I mentioned, institutions and social capital, even more important than the direct kill, the direct punishment of people. There is now, we have more dangerous issue that we have institutionalization of this conflict within the institutions, social capital relations, and the conflict economy. I don't want to go through this. It's now the jump in the prices. It's not because of Corona alone. It's not because of the crisis in Lebanon. We lose the foundation to have a trust in the institution inside the country. It's not about the end of military operations. It's beyond that. And this is the good news that I can build on. The good news that most of the key subjugating actors lost their social support. And when I say 96% of the Syrians are poor or lack of access, when we see the new structure of actors who are controlling the regions, who control it without any kind of acceptance by the social and local societies, when the people see that after the end of military operations and after the defeat of ISIS, we have the same policies, that same humiliation, the same kind of subordination for people, we can say that the social base is huge against the subjugating actors. The second thing is the bureaucratic class and the middle class, all lost during the conflict. So we don't have like a reward for many of those people who are working in the health system, for example, like the health workers. It's the opposite. They are losing social, tangible and intangible assets. So those are as well a potential for social actor who refuse the continuation of the current situation. Of course, I can mention the civil society as well, the humanitarian agencies, although part of them, as I mentioned, are part of the machine of the conflict, sometimes unintentionally. And the last thing, that the subjugating actors failed to control the society, failed to subordinate the communities. After all of that, they feel the instability. And we think that this is a very important part of their losing their foundation or sources of their political power. So I think the most important part of this is to build on who is the losers of the current mechanism and political system, including the people who are suffering from COVID, for example, in different regions, without any support from the quote unquote from the actors who are protecting them. The simple approach that we can think about, and it's just to throw an idea how we can work through the community of refugees and the community inside Syria, between the different regions, we have a common interest across Syria. And we have a lot of experience now through the different network of civil society, private sector, and other non-armed groups who can build this kind of congruences, not a full agreement, just to build a starting point, a new equilibria for more congruences, more acceptance that let's do, for example, our commission for COVID. Let's coordinate in terms of COVID. Let's coordinate in terms of the disabled people. Let's coordinate in terms of the abused women. So we can build a starting point, not to normalize the oppression. It's the opposite. It's dismantling this, but through something that we can build it now. How we can build the trust across the society with a vision to overcome the oppression on the midterm and on the long term. And this is the basis of I think the health is one enormous theme to agree about, like education and food security. So we can understand this as a core to be the first stone in more congruences for the future. And sorry if I took my time.
Rabi, thank you for that. And thank you for, I think, really drawing this all together and really broadening our lens beyond just a narrow health lens and thinking about the gravity of this and the upstream factors. I wish to thank all of the speakers, because I think that sometimes there's a tendency to take a very reductionist, simple approach to places like Syria. And I think that the first step is to really understand and engage with the complexity. And I thank all of the speakers for the passion and their intellect and the expertise with which they spoke. We're going to have to end it there, and I'm sorry we've run over time, but I just wanted to, first of all, thank all the organizers, Aula, Kristen, Diana, and everyone from Syria Public Health Network for really putting together this great discussion. I also really wanted to thank the speakers for your dedication, your time, and your commitment to this. And thank everybody else for their steadfast commitment to this cause and their interest in Syria. This is one in a series of seminars, and I think that this is recorded as well. So hopefully in the chat, you'll see both the link to it, and I'm sorry we've run out of time for Q&A, but some of that hopefully is found on the chat. But thank you once again, and I wish everyone safety and a good evening. Thank you.
Thank you.